volunteered to Jinkian. I want to do pregnancy. The reason is because I see a lot of pregnant women in KK, and when they come, I wish and I hope that I can treat them properly and correctly, because there are two lives in there. I don't want to give them a lot of problems later. So, before I did this, actually there were a lot of things, a lot of medication has been shown to you by Su Xian, that which one can use, which one cannot use. So now I'm going to go through them. My talk will be very scientific paper based. So there will be a lot of papers to show you. So rhinitis of pregnancy is actually defined as inflammation of the nasal passages occurring during pregnancy. All right, and it can be caused by allergic rhinitis, can be infective, and of course, the one that we all will think about when the patient is pregnant is gestational hormonal rhinitis, and it occurs in about 30% of the women of childbearing age. Allergic rhinitis is actually the most common group. All right, it's the most common cause of nasal congestion in pregnancy. So it's still number one. Occurs in 18 to 30% of women. Pregnancy may initiate, or the pregnancy may worsen the pre-existing allergic rhinitis. And the common allergens, usual, same as what Su Xian has told you. Now, gestational rhinitis is defined as nasal congestion for at least 6 weeks of pregnancy without signs of infection, tumor, or allergic rhinitis itself, any allergic cause. It may occur at any gestational week and resolve within 2 weeks after delivery. Occurs in 20% of pregnancies and is due to increase in estrogen or placenta growth hormone. The infective rhinitis is the small group, occurs in 1.5% of the pregnant women. Nasal congestion with prolonged nasal discharge, facial pain and headache are the common symptoms. Although fever has been mentioned in your guidebook, but is seldom seen. Haemophilus influenzae, strep pneumonia were the most common bacteria seen. Some risk factors. Smoking increase the incidence of pregnancy rhinitis. Chronic sinusitis can be aggravated during hormonal changes. And on the good side, diet, fish, and 3 polyunsaturated fat, soil, etc., isoflavone may be associated with reduced prevalence of allergic rhinitis in pregnant women. Symptoms of rhinitis of pregnancy, the symptoms are about the same, all right, except the patient is. Diagnostic imaging studies are usually not recommended, and nasal endoscopy is recommended to differentiate pregnancy rhinitis from sinusitis. Now, I'm going to go through something that, people who deal with medications in pregnancy have to know, which is called US FDA pregnancy risk category, risk to the fetus, all right. When you deal with a drug, they have different levels, risk category level. Level A is a drug that has already had controlled human studies which have failed to demonstrate the risk to the fetus in the first trimester, and possibility of fetal harm is very little. So this is level A. Good. Level B, control studies done in animals only, which indicate no risk to the fetus, and adequate well-controlled studies on human or pregnant women is not really available. Level C, studies on animals show adverse effects and toxicity to the fetus, but there's no adequate or well-controlled studies on human pregnant women yet. But these drugs, the benefits of them may actually outweigh the potential risk in humans, so you may use it. Level D, positive evidence of human fetal risk exists, but the benefits may outweigh the risk in certain situations. The word is certain situations, so it's level D. And level X is contraindicated. Studies in animal and human have demonstrated fetal abnormality, and the risk of use of the drug in pregnancy clearly outweighs the possible benefits. So I will apply that in the following situations. All right. Treatment of rhinitis in pregnancy can be supportive pharmacotherapy and immunotherapy. First, supportive therapy, avoidance of allergens, elevation of the head of the bed to about 30 degrees to 45 degrees may help. Nasal douching with hypertonic saline irrigation, remove mucus from nasal passages, improve discomfort and breathing, and lubricate the nasal mucosa, and of course reassurance as well. So that one can be given to the pregnant woman with confidence. Pharmacotherapy, the first line, and I tell you the second line later. So the first line consists of hormones, topical antihistamines, oral antihistamines, and intranasal steroids. The hormones, no known teratogenic effect, given in the first 3 months of pregnancy without any problem, 3 to 4 times a day. All right. However, this is safe, but it's really weakly to moderately effective. So we usually don't use hormones, and this one is level B. It's quite safe. Antihistamines is following two are actually recommended by American College of ONG, and they are level B. The cofeneramine 4 to 24 mg milligram per day in divided doses can be used. And treponema, 25 to 50 milligram every 6 hours, maximum of 200 milligram per day can be used. Antihistamines, the new ones, cetirizine and loratadine, both are level B, preferably used after the first trimester. I give you some papers on that. Cetirizine, one prospective controlled observational study shows no significant differences in miscarriages, birth weights, or the rates of major or minor malformations found between the cetirizine group and the control group. Okay, and there's another prospective observational cohort study shows major birth defects were not more common in the study group compared to the control group. For the loratadine, in 126 women, this paper shows no increase in the rate of major anomalies in the infants exposed during first trimester when compared to the non-exposed controls. Another prospective paper, 161 women exposure to loratadine did not appear to significantly increase the rate of major malformations. All right, next group, intranasal steroids. I will go on to fluticasone, mometasone, and then to budesonide. All right. I have a lot of friends out there in the the drug companies, but I still have to tell the truth. The papers that come up. I cannot just say they treat me well. I cite them. So so from the papers, fluticasone, you can see in this placebo-controlled randomized double-blind 53 women study, 8 weeks of treatment, 50 microgram per spray, 2 sprays per nose in the morning, shows no significant effects of the treatment on both rhinitis symptoms. So the treatment, it doesn't improve the symptoms, although the pregnant woman as well as the fetal growth is not affected. So not so good lah. Also not effective, so why you want to use it? Mometasone is also level C. Several studies using rabbit rats result in reduction in maternal birth weight gain and effect on fetal growth. There's no adequate or well-controlled studies done in pregnant women. All right, so mometasone, which is Nasonex, is also level C, and only one intranasal steroid, which is budesonide, level B, and it's got a number of 6,600 infants, and they've found to show no association with an increased risk of congenital malformations or other adverse fetal outcome. So this is the only one that you want to use for pregnant women, is budesonide. The second line, topical decongestant, oral decongestants, is only used when you don't have the first line medications. Suppose in some countries you may have to do that. So topical decongestants, oxymetazoline is actually level C. It relieves symptoms, but regular overuse may result in nasal hypoactivity and hypertrophy of the nasal mucosa. Safe, minimal absorption into the bloodstream. However, in this paper, repeated use of nasal spray was associated with a non-reactive, non-stress test and late deceleration in the patient at 41 weeks of gestation. So it's not recommended during label. So decongestant can be used, but you could avoid it during label. Next, the oral decongestants. The oral, whether you want to use it or not, it's actually not recommended in the guidebook which we give up to you. I just show you just to, there are 2 positive and 2 negative. This is a retrospective study of 206 gastrochesis cases. They review that. And the risk of gastrochesis and small intestinal atresia were increased for any use of pseudoephedrine and for use of pseudoephedrine in combination with acetaminophen. And this is another case study. Found a statistically significant association between the use of pseudoephedrine and phenylpropanolamine and the risk of developing of gastrochesis. So these are the positive associations that will tell you not to use during pregnancy. And we also found 2 papers which actually say it's all right, but we decided not to recommend. This paper, 2,474 pregnant women using phenylpropanolamine or phenylephrine was shown to have no teratogenic effect, but with protective effect on premature birth and low birth weight. And this one also tried to show us that phenylpropanolamine 50 mg twice a day is an effective and safe treatment in pregnancy rhinitis. No effects on blood pressure and other side effects were detected. I will give you a principle and why we don't recommend that to you. All right, oral decongestant. Next group is for infective rhinitis during pregnancy. Amoxil is a level B drug, population-based study. 400 pregnant women exposed to amoxil, no increased risk of adverse pregnancy outcome associated with amoxicillin exposure during pregnancy. Augmentin, which is fluroxyclev, is also a population-based study. Treatment of pregnant women, 2nd or 3rd month, is in the usual therapeutic dose is unlikely to increase the risk of congenital abnormality in the newborn. So if amoxil used and is not effective, you can actually change to augmentin without any problem. Cephalosporin, level B as well, no problem. And metronidazole is level B. You can use it if the organism is anaerobe. All right. Immunotherapy, no teratogenic effect and clinically useful in improving symptoms. It's not recommended to start though during pregnancy, but maybe continue if maintenance phase has been achieved. So you can continue by doing that. In conclusion, I would leave the algorithms for you to look through. They are quite straightforward. The important points for you to note is rhinitis of pregnancy is a common condition with various treatment options. Maternal and fetal safety should be the most important when choosing the appropriate therapeutic strategy. Ideally, all drug therapy should be avoided during pregnancy, especially in the first trimester. And if drug therapy cannot be avoided, treatment choice usually depends upon the predominant symptom. And topical agents are considered first line as these have minimal systemic exposures and applied most appropriately to decongestants. With this, I thank you for your attention.